seen is the external oblique, internal oblique, and transverse abdominis. Okay, and some of the certain things which we need to stress upon is regarding the external oblique muscle. The external oblique will be extending from pubic tubercle to anterior superior iliac spine. Okay, the lower part of the external oblique muscle will be folded on itself to form the inguinal ligament. Just a second, let me see. Yeah, someone has recorded it. Okay. So that will be the superficial inguinal ring. So this is a defect which is located, okay, above and medial to this pubic tubercle. Okay, so you know this is a pubic tubercle, just medial to the pubic tubercle. There is a defect in the external oblique aponeurosis. So that's called a superficial inguinal ring. Okay, and there is also a deep inguinal ring which is present in the fascia transversalis. Okay, so you know external oblique, internal oblique, transverse abdominis, then fascia transversalis. So in fascia transversalis there is a defect, okay, and that is called as deep inguinal ring. Okay, now there are certain structures which pass from the superficial inguinal ring to the deep inguinal ring and otherwise also. Okay, so from along this, between this superficial and deep inguinal rings, especially in male, okay, there are certain structures which pass, and the way in which they pass is called as the inguinal canal. Okay, the way in which they pass is called the inguinal canal. Okay, this is the internal oblique muscle. Okay, we have covered this in the last session. Okay, and this is the transverse abdominis muscle. Okay, and its nerve supply. Okay, also we have seen the conjoint tendon. The conjoint tendon formed by the union of the transverse abdominis aponeurosis and internal oblique aponeurosis. Okay, transverse abdominis and the internal oblique aponeurosis. You can see both of them are passing anterior to the rectus sheath in the lowermost part. Okay, so both the internal oblique aponeurosis and transverse abdominis aponeurosis passes anterior to the rectus sheath. Okay, both of them they pass anterior to the rectus sheath. Okay, and behind you can see there is only fascia transversalis. Okay, and this is the rectus abdominis muscle. Okay, and below the rectus abdominis muscle you can see a small muscle which is called as pramedialis. Okay, pramedialis. Okay, usually it doesn't have any function. Some would say that they are having, they tense up the linea alba, okay, and reinforce the lower part of the abdomen. Okay, so this is pramedialis and this is the rectus abdominis, and you can see that the rectus abdominis has got tendinous intersections. Okay, and these tendinous intersections are attached to the anterior rectus sheath. Okay, they are attached to the anterior rectus sheath. Okay, so one is at the level of the umbilicus and the other one, okay, approximately halfway between xiphoid and umbilicus, and the other one is halfway between the umbilicus and the pubic symphysis. Okay, these tendinous intersections. So here the muscles are divided into groups so that it helps in flexion of the spine. Okay, the anterior flexion of the spine. Okay, those are the origin and insertions. Okay, all right. So the main actions of the anterior abdominal wall muscle, they help in increasing the intra-abdominal pressure, especially when someone does helps in weightlifting. So what happens when you're about to carry something heavy? Okay, so you catch hold of the breath and the intra-abdominal pressure increases, right? And also it helps during vomiting, okay, coughing, delivery, okay, micturition, defecation. Okay, so all this, the anterior abdominal wall acts, raising the intra-abdominal pressure. Okay, This you already know. It helps keep the abdominal viscera in its position. The rectus abdominis has got an additional function, like it helps in bending the spine, and they also act as an accessory expiratory muscles. That is, during normal expiration they will not act, but whenever they do a forceful expiration, you can feel that your abdominal muscles are contracting. Okay. All right. So the rectus sheath, we were discussed this also the last time. So the anterior rectus sheath. Okay. So yeah, here you can see the anterior rectus sheath. It is formed by external oblique aponeurosis and the anterior lamina of the internal oblique aponeurosis, and the posterior rectus sheath is formed by transverse abdominis aponeurosis and the posterior part of the internal oblique aponeurosis. Okay, both the anterior and the posterior rectus sheath, they join in the midline, and that is called as linea alba. Okay, linea alba. Lateral to this rectus abdominis, so that's called as linea semilunaris. Okay, linea semilunaris. Okay, now if you make an incision here, you come across skin, superficial fascia, both membranous and fatty layer, the linea alba, fascia transversalis, and then the peritoneum. Okay, so exactly if you make an incision in the center. Okay, but usually in most surgeries they do not perform a midline incision. Okay, because the linea alba is devoid of any blood supply, so healing will take a longer time. Okay, and also the strengthening of the uh, of the linea alba will take a quite a longer time. Okay, and that could be a possible for herniation. Okay, so that's why they do not make, usually they do not make a midline incision. Okay, they make a paramedian incision. Okay, they make a paramedian incision depending on which area the pathology is. Okay, so here I have given you the how it is formed. Okay, so here you can see the anterior rectus sheath formed by external oblique aponeurosis and anterior layer of the internal oblique aponeurosis, and the posterior rectus sheath is formed by the posterior part of the rectus abdomen, the posterior part of the internal oblique aponeurosis and the transverse abdominis aponeurosis. Okay, so this is about
Sir,
the yes.
sir, I had a question. You said about conjoint tendon, right? That all the three muscle aponeurosis, they come to the anterior aspect and form the conjoint tendon, right? This happens
Yes,
at the lower part. So on the
yes,
upper part, the internal oblique, it separates into the anterior and posterior part?
yes,
Okay.
yes.
Okay,
But
thank
in
you.
the lower part, I think there is no slide on that. But okay, but in the lower part, what happens is all the three, the aponeurosis of external oblique, internal oblique, and transverse abdominis, all three will be forming the anterior rectus sheath. Okay, all three will be passing above. Okay, and they forms the anterior rectus sheath, and there is no posterior rectus sheath. Okay, halfway below the umbilicus, there is no posterior rectus sheath. There will be just fascia transversalis and peritoneum. Okay, there will be fascia transversalis and peritoneum. Okay, now the part, okay, the exact part where this sheath goes above and the posterior rectus sheath disappears, and that is called as arcuate line. Okay, it's called as arcuate line. Okay, I don't think I have a picture. I'll just see like if I can find it somewhere. Okay, no, I don't have a picture. All right, I'll see like we'll just see like if I have a picture. Okay, so the posterior rectus sheath, the
Doctor, can you
posterior
repeat that word? What line? Are
arcuate line. Okay, I'll
okay.
just type it here. Okay, it's called as arcuate line. Okay, it's called as arcuate line. Okay, the exact part where the posterior rectus sheath turns into anterior rectus sheath. Okay, that is both all the three aponeurosis, they go above. Okay, the posterior rectus sheath, there will be a line. Okay, and that is called as arcuate line. Okay, all right, the fascia transversalis. Okay, so this is present deep to the transverse abdominis muscle, and it is continuous with the fascia of the diaphragm and the iliac muscle. It is also continuous with the femoral sheath. Okay, then deep to it will be the peritoneal fat, that is the omentum, and the parietal peritoneum. Okay, these are some of the different incisions. You need not know the name of the incisions, but know what are the structures which you go through. Okay, so say for example, if I make an incision here, which layers of the abdomen I will pass through. Okay, so you need to know that skin, the superficial fatty membranous layer. Okay, then what are the other layers? The anterior rectus sheath will be there. Okay, you cut open the anterior rectus sheath, rectus abdominis, then posterior rectus sheath. Okay, and once you cut the posterior rectus sheath, fascia transversalis, then peritoneum. All right, and this is the name of the incision which they usually give it for. The number one is the incision which they give for gallbladder, because you know that the gallbladder is located here, right? So in gallbladder surgeries, they use this incision, which is called a subcostal incision, or the name of the person who devised it, it's called as kosher incision. Okay, so this is for general laparotomy. Okay, number 2 and 6. Number 3, 4, and 5 can be used for appendicitis. Usually it is done for appendicitis. Okay, it's the McBurney's incisions, Battle's incision, or Land's incision, depending on the surgeon. Okay, so they can use any of these incisions. Okay, number 8. Okay, so what is located here? The sigmoid colon. Okay, so in case of any colonic pathology, okay, in the descending colon, in the sigmoid colon, if there are any pathology like cancer colon, okay, so they will do the surgery here. They make an incision here. Okay, and this is the incision which they do for C-section, fan and steel incision. Okay, or it is called as above the pubic symphysis, they make an incision. Okay, so that it's also for cosmetic reasons. Okay, also for cosmetic reasons, because the incisions will be less visible. Okay, so these are the different incisions. You need not know the name of the incision, but you should know what are the layers of the abdomen which you encounter when you make during this incision. Okay, I finished until that part in my last class. Okay, so now here you need to find what is this Hasselbachs triangle. Okay, and also like what are the reasons behind this median umbilical ligament, medial umbilical ligament, lateral umbilical ligament. I think this has been covered in your peritoneum class as well. Am I right? Okay, so this one you try to find out from the peritoneum class. Okay, so what are this? Behind this median umbilical ligament, there is an embryological structure. Behind this medial umbilical ligament, there is an embryological structure. Lateral umbilical ligament, there is.
Is it the umbilical arteries?
Yes.
Umbilical
Okay.
veins?
Yes, umbilical arteries, umbilical veins. Good, very good. Okay, so that's it. Now coming to what is the Hasselbachs triangle? Hasselbachs triangle, I will just show you. Before that, you need to know what is the deep inguinal ring. The deep inguinal ring, as I said, it is present in the fascia transversalis. Okay, half an inch above the line joining the inguinal ligament. Okay, that is between the anterior superior iliac spine and pubic symphysis. Okay, this is called as mid-inguinal point. Okay, this is called as mid-inguinal point. Okay, so take the midpoint between anterior superior iliac spine and pubic symphysis, and take half an inch above it, that's the approximate location of the deep inguinal ring. Okay, the deep inguinal ring. Remember, this is different from midpoint of the inguinal ligament. Okay, midpoint of the inguinal ligament. Where does the inguinal ligament extend from? It extends from anterior superior iliac spine to pubic tubercle. Okay, not symphysis pubis. Okay, the inguinal ligament extends from anterior superior iliac spine to pubic tubercle. Okay, not pubic symphysis. Okay, so that is called as midpoint of the inguinal ligament. That is between anterior superior iliac spine and pubic tubercle. So that's called as midpoint of the inguinal ligament. Now this one, from anterior superior iliac spine to pubic symphysis, that's called as mid-inguinal point. Okay, it's called as mid-inguinal point. I will just show you the picture. Yesterday I showed it in the practical class to some of them. Okay, so yeah, here it is. Okay, so here you can see this is the mid-inguinal point from the pubic symphysis to anterior superior iliac spine. This is mid-inguinal point. Midpoint of the inguinal ligament, it is different. Okay, so midpoint of the inguinal ligament is from anterior superior iliac spine to pubic tubercle. Okay, usually the midpoint of the inguinal ligament is the reference point. Half an inch below it will be the femoral artery. Okay, so that is the reference point for femoral artery. Whereas mid-inguinal point, half an inch above it, will be the deep inguinal ring. Okay, will be the deep inguinal ring. Okay, so that you might be asked in your multiple choices, is it mid-inguinal point or midpoint of the inguinal ligament? So that you need to know. Okay, now let's come to the inguinal region. So that's the inguinal region.
Sorry, can you repeat it again? Sorry, the difference.
Please mute your other, the person who talked. Okay, please mute your other devices. Okay. Okay, so the mid-inguinal point is between anterior superior iliac spine and pubic symphysis, whereas midpoint of the inguinal ligament is anterior superior iliac spine and pubic tubercle. Okay. Now we will be seeing the inguinal region. The inguinal region, it will be covered by Dr. Kumar, but I'll just cover it up. Okay, a little bit. So you know, these are the surface marking which you can, which you need to know. So the iliac crest, anterior superior, this is the iliac crest, anterior superior iliac spine, pubic symphysis, pubic tubercle. Okay. So this is the midpoint of the inguinal ligament. Okay. Sorry. I'm sorry. Now this is wrong. Okay, I'll make the change here. The midpoint of the inguinal ligament is for femoral artery, and mid-inguinal point is for femoral artery. Okay, so midpoint of the inguinal ligament, it is for femoral artery. I'll make the changes and then I will project this again. Okay, so it's been mentioned wrongly in this PowerPoint. Okay, now the inguinal ligament. As I said before, the inguinal ligament, it is formed by the free edge of the external oblique aponeurosis. Okay, the free edge of the external oblique aponeurosis. Okay, and it extends from anterior superior iliac spine to pubic tubercle. Okay, all right. So this is the inguinal ligament. Also, the inguinal ligament provides origin for internal oblique muscle and transverse abdominis muscles. Okay, they provide origin for the internal oblique and transverse abdominis muscles. Okay, the fascia lata is also attached to the inguinal ligament. So you know that the inguinal ligament, which is coming from the external oblique aponeurosis, has got much significance. It gives rise to two more muscles, which is internal oblique and transverse abdominis. and also the fascia lata of the thigh. Okay. All right. Then there is something called as lacunar ligament and pectinate ligament. Okay. The lacunar ligament and the pectinate ligament. What are this lacunar ligament and pectinate ligament? Okay, this you might have covered this in your lower limb. Okay, in your lower limb when talking about the femoral hernia. Okay, you can know that this is the inguinal ligament, which is extending from anterior superior iliac spine to pubic tubercle. Now, if you see, there is a triangular portion here, a triangular extension of the inguinal ligament, which is attached, okay, which is attached to the pectinate line. Okay, pectinate line. This triangular portion is called as a lacunar ligament. Okay, this triangular portion is called the lacunar ligament, and this part is called as the pectinate region, pectinate ligament. Okay, these are the extensions of the inguinal ligament. This, especially in case of femoral hernia, you need to know. Okay, if you remember in your lower limb class, okay, when we were telling to extend, okay, if you want to extend the femoral ring, okay, the femoral ring, this is the femoral ring, you need to cut through the lacunar ligament. Okay, so this is the lacunar ligament, which is nothing but a part of the inguinal ligament, and this is the pectinate ligament. Okay, this is the pectinate ligament. Okay, so that's the lacunar ligament. Okay, and that is the pectinate ligament. Okay, which is indicated in the purple dots. Okay, purple dots, that's the pectinate ligament. Okay, so suppose if you want to widen up the femoral ring, okay, so you need to cut through the lacunar ligament. Okay, you need to cut through the lacunar ligament. Okay, now the inguinal ring, inguinal canal, as I said before, it is extending between the superficial inguinal ring and deep inguinal ring. Okay, so here they have given a different name, external ring and internal ring. Okay, so this is the superficial inguinal ring, which is a defect in the external oblique aponeurosis, and deep inguinal ring, which is a defect in the fascia transversalis. Okay, so this is an oblique canal which is extending from the superficial inguinal ring to the deep inguinal ring. Okay, and you know that there are certain structures which goes towards the scrotum. Okay, the spermatic cord comprising of vas deferens, testicular artery, testicular vein. Okay, so here you can see that's the inguinal ligament. Okay, and this is the superficial inguinal ring. The deep inguinal ring will be located somewhere in the fascia transversalis here, and the connecting part would be the inguinal canal. Okay, and the spermatic cord passes through them. Okay, all right. Okay, now these are the relations of the inguinal canal. Okay, so which has been dissected. Okay, so here this is the external oblique muscle, external oblique aponeurosis, and here you can see the defect in the external oblique aponeurosis, which is the superficial inguinal ring. Okay, through which the spermatic cord passes through. All right. Now, once you cut the external oblique aponeurosis, you will be able to see the internal oblique. You can see the internal oblique has taken origin from the inguinal ligament. Okay. So the internal oblique aponeurosis. So the internal oblique aponeurosis forms the roof of the inguinal ligament. So imagine it's like a tunnel. It's like a tunnel. Okay, the roof of which is formed by the internal oblique muscles. Okay, the internal oblique muscle as well as the transverse abdominis muscle. Okay, internal oblique and transverse abdominis muscle. Okay, the roof is formed by internal oblique and transverse abdominis, the roof of the inguinal canal. Okay, now the floor the floor, it is formed, the floor of the inguinal canal, it is formed by the inguinal ligament as well as the lacunar ligament. Okay, it is formed by the inguinal ligament and the lacunar ligament. Okay, anterior relations, you already know the same layers which you come across, which is skin, superficial fascia, external oblique aponeurosis, internal oblique aponeurosis. Okay, so those will be the anterior relations, and posteriorly, you know, the relation is fascia transversalis. Okay, fascia transversalis, and laterally there will be conjoint tendon medially. Okay, there will be conjoint tendon. Here you can see the conjoint tendon, which is the union of the internal oblique and transverse abdominis muscle. Okay, so the anterior relation, posterior relation, roof and floor of the inguinal canal. Okay, so these are the anterior and posterior roof and floor, the relations of the inguinal canal. Okay, so the inguinal canal relationship is very important, not only from the anatomical point of view, from surgical point. Okay, so these questions will be asked even in your final year. Okay, so describe about the inguinal canal and what are its relations. Okay, so this you need to know. Any doubts until now? Do you have any doubts? One of you can unmute me and tell. Okay. The next one, we are going to the next part. Yes.
Actually, doctor, I had a small doubt.
Yes.
You said that the mid-inguinal point is a reference.
Yes,
point.
I will tell that. I will tell that later. Okay.
Okay, fine.
I will tell that because in this PowerPoint it has been mentioned wrongly. Okay, so I need to clarify that. Okay, I
Okay.
want to for what is that and how the anatomy book gives and the surgical books. Okay.
All right.
All right. I will be emailing you regarding that. Okay. Now this one is the inguinal canal. So you can see the deep inguinal ring, the superficial inguinal ring. You can see the deep inguinal ring is a defect in the fascia transversalis. Okay. And the superficial inguinal ring in the external oblique aponeurosis. This is the conjoint tendon. Okay. And you can see the structures, certain structures are coming through this inguinal canal. Okay. And getting into the perineal region. Okay. Now the inguinal canal in males. Okay. The inguinal canal, it is more prominent in males. Why? Because of the presence of scrotum, and there are certain structures which goes towards the scrotum, which is called as spermatic cord. Okay, the spermatic cord, which is comprised of testicular artery, testicular veins. Okay, and also the vas deferens. Okay, the vas deferens which conducts the sperm from the testis to the urethra. Okay, so these are present in the spermatic cord. And also there is a nerve which comes along, which is the ilioinguinal nerves. Okay, the ilioinguinal nerve. The sympathetic nerve also comes, and some lymphatics also comes. Okay, through the inguinal canal. Okay, it comes out through the inguinal canal. Now, since scrotum is not present in females, okay, so that doesn't mean the inguinal canal is not present in females. Inguinal canal is present in females also, but the superficial inguinal ring is not as big as in males. Okay, so the inguinal canal is present even in females, and there are certain structures which pass through it, which is the round ligament of uterus. Okay, the round ligament of uterus, which is attached to the labia majora. Okay, so this you will be seeing it in the genitourinary module again, the round ligament of uterus. So in males it is spermatic cord, and in females it is the round ligament of uterus. Okay. Okay, now the Hasselbachs triangle. Okay, the Hasselbachs triangle. What is this triangle and what is its importance? It is formed by, okay, it is formed by the inguinal ligament. Okay, the base is formed by the inguinal ligament. The medial border is formed by the lateral part of the rectus abdominis. Okay, the lateral part of the rectus abdominis. And the lateral portion is formed by the inferior epigastric artery. Okay, inferior epigastric artery. So this is the Hasselbachs triangle. Okay, the Hasselbachs triangle. Okay, that is between the lateral border of the rectus abdominis, inguinal ligament, and inferior epigastric artery. Okay, this is the Hasselbachs triangle. Now, why should I know about this Hasselbachs triangle? Because in direct hernia, the abdominal contents will be coming out through this space. Okay, I will tell you what is direct inguinal hernia now. Okay, now let me see. Okay. Okay, now what happens? See, this is here you can see once again the superficial inguinal ring, deep inguinal ring, and the contents are passing through it, right? Now, suppose in case if the anterior abdominal wall, okay, so if there is an increased pressure inside the abdomen, okay, so you know there are many contents, intestines, okay, so they are present inside the abdomen, okay, and what happens if it is weak, the contents can come through the deep inguinal ring, through the inguinal canal, and into the superficial inguinal ring. Okay, so this is called as indirect inguinal hernia. Okay, indirect inguinal hernia. Okay, so the indirect hernia, the pathway which it takes is deep inguinal ring, inguinal canal, superficial inguinal ring. Okay, so this is the normal course of indirect inguinal hernia. Okay, indirect inguinal hernia, they take the normal course from the deep inguinal ring to the superficial inguinal ring. Also the congenital inguinal hernias. There is something called as congenital inguinal hernia. So what is the meaning of congenital inguinal hernia? That is present right from birth. You know that the testis is initially getting developed inside the abdomen and slowly it is brought outside into the scrotum. Okay, so sometimes along with this scrotum there will be an extension, of the peritoneum as well as the intestines which comes down. Okay, the intestines can come along with the testis, so that is called as congenital indirect inguinal hernia. Okay, congenital indirect inguinal hernia. Now, what is direct hernia? Direct hernia usually occurs in old age. Okay, in old age people, when the anterior abdominal wall is weak. Okay, when the anterior abdominal wall is weak, especially near the Hasselbachs triangle. Okay, so what happens? This is a weak area. That's why this is called as Hasselbachs triangle. We are giving importance to it. Okay, so what happens in this case? The Hasselbachs triangle is weak. So the intestinal contents come directly through this Hasselbachs triangle and it will be projecting through the superficial inguinal ring. Okay, so it will not pass through the deep inguinal ring. Okay, the inguinal it will pass the later part of the inguinal canal, but it will not pass through the deep inguinal ring, the direct inguinal hernia. Okay, once again I am telling you, in indirect inguinal hernia it goes through deep inguinal ring, inguinal canal, superficial inguinal ring, whereas in a direct hernia it passes through the Hasselbachs triangle. It passes through the Hasselbachs, the intestinal contents come through the Hasselbachs triangle, and then it will be projecting out through the superficial inguinal ring. Okay. Now, what you need to know, why should I know about this? Okay, so direct inguinal hernia and indirect inguinal hernia, the treatment is different. Okay, what is the defect in the indirect inguinal hernia? The deep inguinal ring is quite big. Okay, the inguinal canal is quite big. Okay, so what you need to do is you need to reduce the space. Okay, so in surgery what they usually do is, okay, this you need not remember, but I'm telling you. So what they usually do is they obliterate. Okay, they close the deep inguinal ring. Okay, and make it make the inguinal ring, the entire fascia, to be tied along with the inguinal ligament. Okay, the inguinal ligament. In case of direct inguinal hernia, okay, because this is a weakness here. Okay, so here also they just need to pull out the fascia here, okay, and stitch it along with the lacunar ligament, so that reinforcing the weak spot, okay, in the anterior abdominal wall. Okay, so sometimes they may keep even a mesh, okay, a net-like structure, okay, over this Hasselbachs area, okay, so that the intestinal contents will not come out. So here they need to strengthen the anterior abdominal wall, okay, whereas in an indirect inguinal hernia they need to obliterate the deep inguinal ring as well as the inguinal canal, whereas in a direct inguinal hernia they need to strengthen the Hasselbachs space, okay, the Hasselbachs triangle, by means of a mesh or by reinforcing it with the inguinal ligament. Okay, so this is the difference between direct and indirect inguinal hernia. Okay, but the main part which you need to remember is Hasselbach's triangle and what is the what are the boundaries of the Hasselbach's triangle. Another point, how to differentiate clinically indirect inguinal hernia from a direct inguinal hernia. Okay, indirect inguinal hernia and a direct inguinal hernia. Okay, the indirect inguinal hernia, it will be passing through the deep inguinal ring, okay, the superficial inguinal ring. So you ask the person to lie down, reduce the swelling. The swelling will be going back inside the abdomen when the patient lies down, okay, and then you close the deep inguinal ring, okay, with your finger. Okay, close the deep inguinal ring with your finger. Okay, and now ask the person to cough. Okay, ask the person to cough. Okay, if the swelling comes out, okay, it means it's a direct inguinal hernia. If the swelling does not come out, it is an indirect inguinal hernia. Okay, I will repeat once again. In an indirect inguinal hernia, okay, because it comes through the deep inguinal ring, you close or give a slight pressure over the deep inguinal ring and ask the person to cough. Okay, cough, because the cough increases the intra-abdominal pressure and the intestinal contents tend to come out. Okay, so you give a slight pressure over the deep inguinal ring and ask the person to cough. If the swelling is not seen, it is an indirect hernia. If the swelling is seen, even though you are compressing the deep inguinal ring, and if the swelling is seen, then it means that it is the direct inguinal hernia. Okay, do you have any doubts in this? This is very important. Okay,
Doctor, how do we treat the Hasselbachs? I mean, the direct hernia. You said that
treatment.
we need to reinforce with the lacunar ligament. Yeah. What are we reinforcing?
This
Doctor, you're lagging.
Yes, so the trouble has started again. Are you able to hear me now?
Yes, doctor.
Okay.
Sir, how do you close the deep inguinal canal ligament or ring?
Doctor, we can't hear you.
Doctor, we're not able to hear you. Doctor, we can't hear anything.
Sorry, again it got disconnected. Yes, someone asked me how do you close the deep inguinal ring? You cannot close the deep inguinal ring. Okay, so what they do is they obliterate the inguinal canal. Okay, they obliterate the inguinal canal by joining the conjoint tendon and the inguinal ligament. Okay, they join these both, the conjoint tendon and the inguinal ligament. They both join this together, thereby obliterating the space. Okay, they are obliterating the inguinal canal. Okay, so when the inguinal canal is obliterated, the hernia cannot come out. All right. Any doubts? Any doubts until now?
This is to treat indirect hernia, right?
Yes, indirect inguinal hernia. For a direct hernia, you need to put a mesh. Okay, for the direct hernia, usually you need to put a mesh. Okay, that is a net-like structure, which is called as hernia wrapping. So what they do is they keep a mesh over this area, Hasselbachs triangle, reinforcing the anterior abdominal wall, that is strengthening it, okay, by means of keeping a mesh. Okay, all right. Okay, so there are many different types of hernia. So I have discussed only the inguinal direct and indirect hernia. The other different types of femoral hernia, which was discussed in your musculoskeletal, but it can come here again. Okay, so that will be taken up by Dr. Kumar. Okay, the umbilical hernia. Okay, umbilical hernia, it can be congenital. Congenital means sometimes you must have observed in children, the umbilicus will be protruded out. Okay, so that is called as congenital umbilical hernia, or acquired in case of repeated surgeries. Okay, repeated abdominal surgeries. Okay, so that could be an umbilical hernia as well. Okay, that's actually called as para-umbilical hernia. Acquired is actually called as para-umbilical because usually the hernia comes out just below the umbilicus. Okay, especially in females who have undergone a lot of surgeries. Okay, for C-sections. Okay, then epigastric hernia is occurring in the epigastric region. Incisional hernia, that is after surgery. Okay, and Spigelian hernia is the hernia of the linea semilunaris. Okay, so here I have described about the indirect inguinal hernia. This is just the same. So the congenital indirect inguinal hernia. So what happens when the testis is descending? A part of the peritoneum is brought along with them. Okay, part of the peritoneum you can see. Initially, the testis is present here in the abdomen. It is developing in the abdomen, and slowly it is brought into the scrotum. So when it comes down, it also brings the layer of peritoneum along with it. Okay, it also brings the layer of peritoneum along with it. Okay, and these forms the covering of the testis. Then later on, this space get disappeared. Usually, the space, the coverings between the testis and the peritoneum, it is disappears. If it is persistent, it is called as processus vaginalis. Okay, processus vaginalis. Okay, so this part is called as processus vaginalis, the blue colored portion. It's called as processus vaginalis, which is nothing but a portion of the peritoneum along with the anterior abdominal wall structures. Okay, so that is the external oblique aponeurosis, internal oblique aponeurosis, and the transverse abdominis, they come down. Okay, then later on, after they come down, after they descend, what happens? The space between the testis and the peritoneum, they get obliterated. If they do not get obliterated, then they form what is called as congenital indirect inguinal hernia. Okay, congenital indirect inguinal hernia. Also, another point, suppose even many surgeons makes this mistake. So they may think that it is a direct hernia. Okay, and once they open, they can they find out that it is an indirect hernia. Okay, or the otherwise, vice versa. Okay, surgically. Now, what I told previously was clinically. Clinically is you just press over the deep inguinal ring, ask the person to cough. Okay, and then you if the swelling does not come out, it is an indirect hernia, right? Okay, right. Now, surgically, how can I find out if it is a direct or indirect hernia? The inferior epigastric artery forms an important landmark. Okay, and you can see the deep inguinal ring is lateral to the inferior epigastric, artery. Okay, the deep inguinal ring is lateral to the inferior epigastric artery. All right. So if you see the swelling, okay, if you see the defect, the deep inguinal ring is quite bigger. Okay, so that means that it is an indirect hernia. Okay, or if you see the intestinal contents protruding medial to this inferior epigastric artery, it is a direct inguinal hernia. All right. So if it is lateral, if the swelling is lateral, okay, the hernial sac. Okay, if it is lateral to the inferior epigastric artery, it is an indirect, and if it is medial, it is direct. Okay. So that's what I told you here. So the sac, if the deep inguinal ring, if the hernial sac, it is lying lateral to the inferior epigastric vessels, it means it's an indirect hernia. If it lies medially, it is a direct inguinal hernia. Okay. Sometimes they will use the term complete. Okay. They will say complete congenital indirect inguinal hernia. Okay. Complete congenital indirect inguinal hernia. What is the meaning of complete here? If the sac, okay, touches the bottom of the scrotum or the labia majora, okay, so it is called as complete indirect inguinal hernia. Okay, usually complete hernias are mostly congenital in origin. Okay, complete indirect inguinal hernias are mostly congenital in origin because of the presence of processus vaginalis. Okay, this you will be discussing once again in your genitourinary module. Okay, when discussing about the testis, we will be seeing it. Okay, and testis has got some certain coverings, right? So these coverings of the testis are also derived from the external oblique aponeurosis, internal oblique aponeurosis, and the transverse abdominis. Okay, so in Dr. Kumar's one, he has mentioned external spermatic fascia, internal spermatic fascia. Okay, so those are nothing but the derivatives of the external oblique aponeurosis, internal oblique and transverse abdominis aponeurosis, which covers the testis. Okay, these cover the testis. All right. So here, can you tell me which hernia is this? One of you can unmute. You can see the hernial bulge is coming through the superficial inguinal ring. So this is an inguinal hernia. Is it a direct or indirect?
Indirect, doctor.
Yes, it's an indirect. You can see that it is coming through the deep inguinal ring and also the inferior epigastric artery. It is lying lateral to the inferior epigastric artery. Okay, it is lying lateral to the inferior epigastric artery. So this is an indirect inguinal hernia. Okay, the direct hernia, as I said, it is just opposite. It comes through this Hasselbachs, the weakness in the Hasselbachs triangle. It comes through the superficial inguinal ring, but does not pass through the deep inguinal ring. Okay, so these are some of the differences. You can go through it between the direct and indirect inguinal hernia. This is a very important class. Okay, not only for anatomy aspect, even in your later years. Okay, so please understand what is the difference between direct and indirect inguinal hernia. Okay, when you go to surgery, they will be asking you like how to find out if it is a direct and indirect inguinal hernia. Okay, sometimes they may not ask the anatomical basis of it. Okay, you should know also what is the anatomical basis for the clinical tests which you do. Okay, all right, so these are the other questions, okay, which you need to know. Okay, so the anterior arterial supply, you know what is caput medusae? I discussed this. Caput medusae is the dilatation of the anterior abdominal wall veins, okay, especially in cases of portal hypertension. Okay, defensive mechanism for the inguinal canal, that is normally why a normal person does not get an inguinal hernia. That is because the anterior abdominal wall is strong. The development of the inguinal canal, so that's what we discussed. Okay, how to distinguish inguinal hernia from a femoral hernia. This I want you to find out and tell me. Can you tell me now, anybody, how to distinguish inguinal hernia from a femoral hernia?
I'm not sure which one, but I think inguinal hernia happens, there's a bulge in the superior lateral aspect of the,
Yes.
and
No,
the femoral.
superomedial. Inguinal hernia, you know pubic tubercle, right? So
Yes.
it is, if it is superiorly and medially, superomedial. If the origin of the hernia, the swelling, it is above the inguinal ligament. Okay, inguinal hernia is above the inguinal ligament. Okay, and femoral hernia is below the inguinal ligament. That you remember. First point. Second point is the superficial inguinal ring. Inguinal hernia comes out from the superficial inguinal ring. Okay, so if it comes from the superficial inguinal ring, which is situated, okay, above and medial to the pubic tubercle. Above and medial to the pubic tubercle. Superficial inguinal ring is located above and medial to the pubic tubercle. Okay, so then it is an inguinal hernia. Whereas femoral hernia, okay, you know that it comes out through the saphenous opening, right? So that is usually located below the inguinal ligament, that is downward and lateral to the pubic tubercle. Okay, if the hernial sac is down and lateral to the pubic tubercle, it is a femoral hernia. Okay, and already I described the clinical tests to distinguish between direct and indirect inguinal hernia. All right, in your Snells, it's given very nicely. You can go through the Snells. If you have any further doubts, you can just email me. All right. You can write present in your chat box and you can leave.